This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, senior attending here, and today we're diving into a topic that is often under-discussed, but critically important in our daily practice.
And I'm Dr. Alara, research fellow. Today we're looking at a fascinating new study from the journal Child's Nervous System, published in 2026. It's a scoping review titled Comparative Analysis of Analgesic Mechanisms in Craniotomy Pediatric Patients, led by Abigail Jenkins and her colleagues from UT Southwestern.
This is a timely paper, Alara. We perform these complex cranial surgeries for tumors, trauma, and congenital issues, but the post-operative period in children remains a bit of a black box when it comes to pain management. Traditionally, there's been a lack of consolidated evidence.
Exactly. The authors point out right in the introduction that there's a persistent misconception that post-operative pain in pediatric patients is minimal. But the reality is that post-craniotomy pain is generally superficial and somatic, involving the scalp, the pericranial muscles, soft tissues, and the dura mater.
That's a key distinction for the residents listening. It's not the brain tissue itself, which lacks nociceptors, but everything we have to go through to get there. And if we don't manage that acute pain effectively, we increase the risk of the child developing chronic pain and a heightened stress response. So, how did the Jenkins group structure this review?
They followed the PRISMA Square guidelines, the preferred reporting items for systematic reviews and meta-analyses extension for scoping reviews. They queried PubMed, Scopus, and Google Scholar through December 2025. They eventually narrowed it down to 24 studies that met their criteria, including 19 retrospective or prospective investigations and 5 case reports or series.
That's a decent sample size for a pediatric neurosurgery review. Over 1,500 patients, right?
Correct, 1,567 patients, with a mean reported age of about 6.3 years. It's a diverse cohort, but the findings highlight some very consistent trends in how we are, and perhaps how we should be, managing these kids.
Let's talk about the pharmacological strategies they identified. I'm assuming opioids still dominate the landscape.
They do. Opioids were the most frequently used analgesics, appearing in 70.7% of the studies. Specifically, morphine and codeine were the most common. However, the review emphasizes the substantial limitations of this approach. As you know, Dr. Aris, the big concern is interference with our neurological examinations.
Right. If a child is oversedated or has meiosis from opioids, it becomes much harder to assess their GCS or pupillary response. We might find ourselves ordering unnecessary CT scans just to rule out a post-op bleed when the patient is actually just experiencing opioid-induced somnolence. Did the paper look at opioid-sparing alternatives?
It did. The review categorized several non-opioid regimens, including NSAIDs like ibuprofen, acetaminophen, and sedatives like dexmedetomidine and propofol. They also looked closely at local anesthetic infiltration and regional nerve blocks.
I'm glad they focused on regional techniques. In my experience, scalp blocks can be a game changer. What did the data show regarding those?
The randomized trials they reviewed showed that local anesthetic techniques and regional nerve blocks significantly reduced both pain scores and overall opioid requirements. And importantly, they didn't see an increase in complications. This supports the move toward what the authors call a multimodal approach.
Let's dive deeper into that multimodal concept. For the students listening, this involves using medications that target different mechanisms in both the peripheral and central nervous systems. Did the study compare the outcomes of multimodal therapy versus single-agent therapy?
Interestingly, the review reported that overall clinical improvement was seen in 61.7% of patients across the studies, and they found similar outcomes between single-agent and multimodal regimens in some metrics. However, the randomized trial specifically favored scheduled non-opioid therapy and blocks because they achieved those outcomes while opioid minimizing.
That's an important nuance. Even if the pain score looks the same on paper, the side effect profile of the multimodal group is likely much better. We want to avoid the respiratory depression and the masking of neuroexams that come with high-dose morphine.
Exactly. The review notes that effective analgesic management reduces the stress response and can improve overall recovery. Since there's an association between acute post-operative pain severity and the development of chronic pain, getting it right in those first 24 to 48 hours is vital.
Was there much mention of specific drugs like dexmedetomidine? We've seen that used more frequently in the PICU lately.
Yes, dexmedetomidine and alfentanil were mentioned among the various analgesics utilized. The study aimed to outline the prevalent indications and contraindications, though it noted that standardized guidelines still remain limited in the pediatric neurosurgical cohort.
That seems to be a recurring theme in our field, the notable deficiency in consolidated evidence. If you look at the mean age of 6.3 years mentioned in the study, you're dealing with patients who often can't accurately describe the quality or location of their pain. We're often relying on behavioral scales or nursing assessments.
Which makes the objective findings of the randomized trials in this review even more valuable. When they see a decrease in opioid requirements, that's a hard metric we can rely on.
So if a resident is rounding with me tomorrow and asks for a recommendation based on this Jenkins paper, what's the takeaway?
The takeaway is that current evidence supports multimodal opioid minimizing strategies. We should be using scheduled non-opioid medications, like acetaminophen and NSAIDs, and utilizing local anesthetic infiltration or nerve blocks at the time of surgery. Opioids should ready be reserved for breakthrough pain, rather than being the first-line around-the-clock solution.
I think that's a very sound approach. It's about being proactive rather than reactive. By the time a child is screaming in pain, their stress response is already through the roof. If we can block those signals at the scalp and dura with local anesthetics and keep a baseline of non-opioids in their system, we're ahead of the curve.
And it's safer for the neuro exam. The authors are very clear that managing post-craniotomy pain is pivotal but must be carefully tailored to address unique physiological differences in children.
Before we wrap up, did the paper suggest where the research should go next?
They emphasize that while this scoping review provides a foundation, further studies are needed to create those elusive standardized guidelines. We have the components, the nerve blocks, the NSAIDs, the limited opioids, but we need more rigorous, large-scale studies to refine the gold standard protocol.
Well, this is a great start. It moves us away from the misconception that these kids don't hurt and gives us a framework to treat them more effectively. Thank you, Alara, for breaking down the methodology and the key findings.
My pleasure, Dr. Aris. It's definitely a paper that every pediatric neurosurgery resident should have on their reading list.
Agreed. To our listeners, remember that effective pain management isn't just about comfort. It's about better neurological monitoring and long-term recovery.
Thanks for tuning in to the Neurosurgery Hub podcast. We'll see you next time.
Goodbye, everyone.